If they become dislocated, they will lock in place. They can get locked in place in a bent position, which is the bent elbow, which I'm not showing you yet, or they can get locked in position in a straight position. You want to splint that, okay, so that the patient is not in extreme pain trying to hold it still themselves, you know, because it's natural to be able to move your arm. And if it's stuck in position, because for some reason there was some extreme force put on the arm, you want to splint to help them hold it in that position. So you're going to take one of these medium-sized boards, or if you have somebody really tall, possibly a longer board. That might be too long.
Mike?
Even on Mike. I need...
What would that be used for?
Mike.
Because it's obviously made for something.
So you want to pad this, because this is going to go in the patient's armpit. And something that I didn't say, but I want to remind you, anytime you use these board splints, you'll notice there's a wood side and there's a soft side. The soft side is always what goes towards the patient's body. Please be mindful of that. So I'm basically going to put this on his arm. Now, notice there's like kind of two sides to this, right? The injured part is the arm. So I'm putting the soft side to the arm. Now there's going to be some void spaces here. You guys see the void spaces? I'm going to pad these void spaces. So my partner is stabilizing his elbow. So here, let's show them the correct way of doing this. So my partner's going to come up and stabilize his injured elbow. I'm going to check pulse. Pulse is present. Can we go to your fingers? Which finger am I touching? All right, so his pulse motor and sensory is good. Now I'm going to insert this. And I'm going to ask my partner to hold that in place. And now I'm going to pad some voids.
Is that like under the wrist and stuff?
So everywhere I see a void, it's going to vary on people. So the first void I see is directly under his elbow. And I don't want to put too much there because that's the actual injury. He actually doesn't have a void under his wrist. And I'm just going to put a little bit under his hand. So notice that his hand is in a natural position right there. You don't really want his hand to be tightened. Like, sometimes you'll need to, depending on the person's hand, put a roll of gauze there just to kind of rest on it. Some people have more curves than others. You just want to put something. Don't have them hold on to it so tight that they're activating all these muscles. You just want it to be a natural curve. Because you guys can all feel in your hand that when you do this, everything tightens, like you're activating muscles and moving tendons and everything. You want it to be in a natural, relaxed position, which is not this. In order to straighten my hand flat, I just activated muscles, moved tendons and ligaments and everything. Okay, so now, this is almost rolled up, so I can use this pretty easily.
That was very impressive. You like rolled up in like one single thing.
Lots of practice.
All right. So again, I'm going to wrap distal to proximal. Now, I'm going to leave a little gap where I can feel the pulse, and I'm going to want his fingers exposed, at least the tips, so that I can check at least capillary refill and a little bit of motor. I literally just left myself a little finger hold to get in there and feel his pulse. And notice how my partner and I have to kind of work very carefully to make sure that he can get his hands around where I have to put the gauze without him letting go of stabilization.
want that like relatively tight too, right?
You want it snug, but you don't want to like pull to super
Right.
stretch it, and because then you're risking cutting off circulation. You just want it snug. You don't want it loose. You'll get a feel for the right tension moment.
Are you like twisting at all, or just?
Nope, no twisting.
Okay.
Perfectly straight. And notice how I'm unrolling it like this. Everybody see the direction I'm unrolling so that it's easy to unroll. Somebody started this beautifully. And notice how I just keep adding more gauze.
You want their arm like slightly bent, or does it depend on?
Whatever position it is locked in, you work with. And notice how I'm trying to catch the padding to kind of keep it on. Okay, so I've wrapped all the way up to the armpit. Now what we can do is I can check, make sure none of this wrapping has taken away a pulse. Still have a pulse. Can you wiggle these fingers? Yep. Which finger am I touching? Alright. And we can lower this down to the side of his body. And what we're going to do is we're going to swath it, right? We can't sling this, right? We're not going to take his arm and go like, oh, you know. So we're going to swath it. We're going to do a couple of swaths here. My partner is still stabilizing. I'm going to go under the good arm and over the injured arm. Now I'm not going to go right on top of the injury. I'm going to tie it to his body above the elbow and below the elbow. And with these, lots of times you're going to have to pull these so that they're on the side of the body, and then you're going to have to pad these. But flat against your body.
That's just a restrictive thing.
Yeah. And kind of the funny thing about this is you may want to ask your patient before you do this swathing to sit down on the cot and lay down, because they're going to have a heck of a time sitting and laying down once you have done this, right? Because this is a really awkward splint, right, if you think about it. And so you have to think about where's your position, where's your patient, how have you handled them. So you want to plan a little bit ahead. Because I've tied these against the body, I need to pad them. At a minimum, I need to go with a second swath. I have the world's shortest arms. I have to do it this way. I need to go below the elbow and do a second one. On some people who are very tall, you may want to do a third that captures the lower part of the board or the lower part of their wrist to their leg. Okay, it's up to you. It's not absolutely like a have to do. This is totally fine because basically the shoulder is immobilized, the humerus is immobilized, the forearm is immobilized, the wrist is immobilized, and we've immobilized the elbow in its straight stuck position, and we've secured it to the body with swaths, and we've held the humerus and the radius and ulna together. We've immobilized them as well.
If you have an injury that like spans the entire arm, you still want to put the swaths on? I mean, even though that's going to cause like pressure.
So we're teaching you basics for like single isolated injuries.
Mm-hmm.
When you get out there and you have craziness, you're going to take all these little basic isolated things that you have and all the fundamentals, and you're going to deal with whatever you have. So you obviously don't want to put something directly on the site of an injury because that's going to cause more harm, right? So sometimes these things are going to have to be modified in the best way that you can modify them. Things aren't always going to be an easy to deal with position.
So to kind of bounce off of that, like let's say there was something with the humerus, could that top for that be slanted a little so it was up higher? Or does
So
it have
you
to be
saying it's his
perpendicular?
elbow and his humerus?
Yeah.
So if that's the case, you could put a board here and here, right? That might fix that.
Yeah, okay.
After I have swath, I am gonna wanna check pulse motor and sensory again. There's nothing wrong when you're doing these complicated splints with checking pulse motor and sensory multiple times to make sure that at some point in the middle, you didn't cut it off. Because if you wait till you check all the way at the end, you won't know at what point something went awry and how to fix it, right? Questions about this?
How would you do the second board over that? Like, how would it needs to sit flat, right? It needs to be flush with. Oh, it'd be a small board. Okay, that makes more
My
sense.
partner would have mega long hands and they would be holding like this,
And they would be.
and I would wrap them together.
Okay.
So yeah, I mean, would you wrap like the first board?
Woo!
Would you wrap the first board and then come back and wrap the second board, or would you do them both at the same
It
time?
doesn't really matter. You could
Doesn't
do them
matter.
individually, or you could do. I mean, yeah.
If you've got both board, can't you just tape them together?
Yeah, you could, and then wrap. Yeah. By the time you're adapting and overcoming,
All the rules are
you
out
could
the door.
do whatever you want that you think is gonna work.
Could you just tell them to suck it up and take them to the hospital?
No, that's not okay.
That's only in Baltimore City, alright?
Yeah.
Right.
Depends where you are. I
When
mean,
you just
you're
sit on
gonna
the bench and
learn.
Put a seatbelt on. We'll be there to see
So
this.
here's the
Yeah, we did that
fundamental
too.
You all, this is important. You're gonna have patients that are so injured, like they have so many injuries, that where you're not even gonna splint these things. You're just gonna throw them on a backboard. That's their splint, and you go. So there are times where you don't even bother fussing with these things.
So like a kid broke his arm on like the playground or something would be a scenario for this.
I mean, yeah, like when it's an isolated and there's not any major systemic multi-system trauma and they're stable, this is when we're doing these little things.
If you do see like